if you're walking into another room, because very young kids are very bad at transferring information from TV to real life. So hypothetically, is that the same issue in VR? Is it not? The difference there might be really insightful for figuring out why that problem exists in young kids in general.
It might also be interesting thinking about the consequences. So I just wanted to bring in the expertise of the audience members, and it sounds like you're coming from a development side, like an interest in development. Yeah. So it's the future of VR development. You just have to sit there being the future. You don't even have to talk. It's like all. So I have some questions that I could lead with, which is for the clinicians in the room, it's like, what do you wish that people coming that are more in my position, where we're doing sort of social science research, it's like, what, if anything, could we look into that would be useful for you that we can do on the ground with non-patient populations, knowing that there's so many differences between what we're doing when we try and pull it into a clinical setting.
Big question.
I know. Yeah. I really put you on the spot because you could say nothing, and that would serve me right.
I have a first thought, which is I think if VR applications for at least acute pain, and we can go back to talking about chronic pain, right, which is sort of a separate beast, for at least acute pain, are efficacious. The next question is, can they be disseminated? Can they be implemented in actual practices? And the big challenges that we've experienced so far, I think, are around are there environments and virtual experiences that people can enter for an indefinite period of time, most likely very brief, and then re-enter or find new experiences and like reuse the same immersion without losing efficacy. I think those are big questions from the technological development side. There are other sort of clinical implementation questions that are equally, if not more important, but are less on the technology side.
In terms of not using enough novelty, would that be accurate to say?
Yeah. Like how much of the efficacy or the distraction of VR is because it's the first time someone's trying it, or just like the brand new experience of being in this virtual space, versus the content is engaging or interesting or valuable to the person in some way, so that they want to stay engaged with. I think that'd be really nice, because I feel confident going into a patient and saying, here's a headset, I'm sure you will be engaged for 10 minutes. Right. And then, like, if that patient stays in the hospital for a month, some patients do, unfortunately, like for 30 days for 10 minutes.
I'm going to follow up, because that's a wonderful question and gets to this issue of, it was an empirical question, have longitudinal studies been done to look at whether effects decay over time to sort of address that or not? We have those studies.
There's like 5. I mean, in terms of social interactions in virtual environments and how people adapt to them, they're truly a handful, which is why I keep telling Nagar she has to get it under review, because it's just having the people's qualitative responses of how they adapted to the environment in a social aspect is important. But so you guys have the longitudinal studies in your sample, though, because you do have participants come back, right? Because if your wound does not heal in a day.
Yeah, right now we haven't. So we've been using. So it's more of an exploratory study at this point. So what we're doing is we're essentially using each patient as his or her control. So we're interested with VR and one without, and randomized to which one they get first, so that it's not that they're getting one versus the other outcomes. But we haven't used it on the same patient multiple times.
Yeah, certainly not in the research, but the opportunity is there clinically, right. That we would like to be offering these things when it's feasible and we have patients that would be appropriate for it. It's an open opportunity, but I'm not aware of really any research in burn pain, at least, which is an area that I know more about. But.
I feel like Hunter Hoffman pulled people in over. I'm trying to walk backward through my mind to find the example. but it might have been sort of a within patient comparisons.
Yeah, I
It's
think
been a period of time.
as far as I know, I think it's all within patient comparison. There's no large series on.
No, there's-
It's the mechanism of supposed to be distraction. I mean,
Yes.
that,
That's
so
the
that
main,
not to
that's the
worry
main.
about it.
Distraction, interactivity, and then people talk vaguely about presence, but I know when people have looked at different environments, it's like if you do an in-hospital environment versus an out-of-hospital environment, then that can have an effect. There's obvious associations why. So yeah, that is a question. That's one reason why I think the social interaction part is interesting, because we do not get bored of interacting with other people. But
I just want to add one piece. So over the session that we had, it was a 5 session. They were coming back each time, and the environment novelty wore off after 2-3 sessions. But then they were exploring new features in that space. So feature novelty wounds, like that's something to my be like if you have 10 features, maybe introduce each of them on each session, and then over time you get that novelty technique at least
Right.
on the thing that I can do. Now like I can hit this ball, and this time I can play this new game with you. Even though the immersiveness gets pretty much like they get comfortable in the environment, but
Yeah.
they can try new.
Did you study like, does it like take into account like different age groups? I feel like obviously if you have like younger children, like they're less likely to like have the novelty of it around. Versus like I feel like both like older populations are more like just like over like after people.
Yeah, my population were undergrad students, and they took the full sample and campus setting. They were like 18 to 24.
could you describe the tasks that you had them do? I'm going to make this paper, I'm going to extract the paper from you verbally.
Yeah. So they were interacting with another participants each time, a new person in Facebook Spaces. They were making their own avatars each time. And then the task, one of them was a fishing game in the virtual space. So they were trying to fish. The other one was to draw and guess. So using a virtual pen, you're drawing something, and the other person should have guessed it. And they were in the VR space for 15 minutes. And then there was brainstorming, finding all the words starting with S and N, as many as you can, and then writing it down. There were brainstorming down. There was a good question I mentioned. There's a
The
lifeboat
lifeboat
task,
task, yeah.
which was more like on the negotiation part. So you have to decide between like rank 10 people on the order, and you have only one lifeboat that fits 5 people. So who you're gonna kill, who you're gonna save. It's like a negotiation, and as a team, you have to get an agreement. So that was just more of a task with team negotiation. So they were doing it with a different person each time. But there was like hours spent that you didn't know the person, and then responding to survey on like workload and sense of presence, and how much I did like the person, and how much I thought that the environment is natural. And there were exit interviews at the end. That's why, like during the interviews, most of them mentioned, yeah, it took me like 2 sessions to get totally comfortable with the environment, like knowing what I'm doing in the environment.
Which could also make people less anxious in the environment too. So you could, I'm kind of curious about the idea where it's like I feel terrified because I can't monitor the external environment. If that was something that might mitigate a little bit when people are like, well, at least I know where I am virtually, as opposed to like I'm lost and also I can't monitor.
Well, and engagement is not the same as not. So, right. This task is data, I think that's what you're saying. As long as there's new tasks to keep engaged, then now the group to do our itself.
There's a way to get out of the hospital, potentially, to remove them from the environment. So longitudinal studies, we don't know much about age range. We don't know that much about, although I was really interested in the fear extinction aspect and how that might apply to patient population. So what are when grants are submitted, do you have a sense of like what are critiques made about the studies in terms of power, in terms of so I have another question, which is What do you guys think about the potential or the problems with doing interinstitutional collaborations? If we say, I have an environment that you could use and the University of Georgia could use and Michigan State can use, all of our patients can use this environment. It's like, what are the problems to doing that where you're pulling in a ton of other collaborators? Like, that's an opportunity and a challenge. Like, what are the challenges?
I think funding is a challenge, but there are places like the Foundation that are trying to get these multi-university collaborations happening because they're really trying to move forward, building open access and so forth. So I think there might be, unfortunately, some clear delineations early on roles of responsibility, funding.
So the funding would come like as you apply, as a group, as a consortium.
And especially as the technology continues to emerge, more accessible and available, how are those costs incurred on each institution? Is it shared asset collaboration? Those things.
Yeah, I think.
Multi-site clinical studies are pretty standard because people can't recruit enough people at single sites usually. So that's a lot of the mechanics of that, the all of that, those tend to be worked out. But I'm thinking in terms of, and we actually have sort of this that we haven't dealt with yet with the PTSD study, is that the technology moves faster than the data collection.
Yeah.
So when a new headset comes out, or when a new whatever, it's the advances are so fast that when you're doing a 5-year study, you might have multiple generations, and you've got to build that. And we don't really build that into the study design. The treatment is the treatment is the treatment.
Right.
We don't think about it changing, evolving.
But it becomes
over the course, but
old-fashioned.
It does.
Yeah.
And particularly when you have, more and more people who are sophisticated consumers of this technology, you can't have someone come in a 5-year, use a 5-year-old headset if they're 25 years old and they've been playing games for, the best. Yeah. So we really don't have mechanisms to build that in our analysis.
And that's not just the headset, but it's like what environment, look at this terrible environment you're showing me with
Do
just
you-
bad animations.
Do you think funders are catching up? There's a classic example when angioplasty, which is a way of taking care of heart disease, and was a competitor to bypass surgery. They did a $20-30 million trial where they were doing angioplasty compared to bypass surgery, and they got the results. By the time the results came out, the angioplaster said, we don't do it this way anymore. So
Right.
basically, you've wasted $40 million because the technology has evolved so rapidly. So you would think that the funding sources would say, well, we can't wait 5 years because we've got to account for this evolution of the technology. So is that happening? Is there evidence?
Unless you do a huge multi-site study.
Yeah.
Which is,
For
and again,
clinical intervention.
Yeah.
You can either do it, focus for a long period of time or really broad for a shorter period of time. But
right.
Start thinking about new study designs.
Yeah.
well, I mean, some of the techniques that allow you to peek at data.
Like Bayesian analysis, or is it?
Bayesian is one of those, but even getting, like in clinical trials,
Clinical adaptive.
right? We have assessment over 3 months, right? So you can possibly get shorter term effects using, apps, get data gathered more quickly over a short period of time. And obviously, you don't get to look at long-term effect, but you can look at what's happening at different levels.
And just to build on not only the technology advancing, medicine also changes. So
Yeah.
in the 5 years, the way we treat certain things, it might not be the same. Yeah. So one of the things that we run into, in terms of our VR study, is that before we would change the room, change the dressing twice a day. So we figure, all right, so this is a good opportunity. But then about 5 years ago, we start using multi-day dressing. So a dressing that has antibiotic impregnated inside the dressing that can stay on for a week. So now we're not changing dressing twice a day anymore. We're changing it a week. So now all those patients start falling off. So yeah.
So there are methodologies that allow to look at this, for example, modular model. That's what I'm sort of talking about. It allows you to look at treatment switching, even from a traditional focus. It's not the best evidence, but it's possible. I have a question. I guess I'm like newer to like the research world. Like in the case where you do have a study where like the technology like advances like during like your long-term study, like what do you do, or like what do you do with like the data from like the older like methods? Like is that still like usable, or what kind of happens to that?
Well, I mean, it has to be,
Right.
but it's also, yeah, I mean, that's what I write about. What happens is that the statistics lag behind the clinical designs. So
is it common to like switch to like the new technology and then just kind of like proceed from there? Like if like halfway through your study, like
I mean, it depends on the study. I know, I mean, we did, Brave Mind got updated multiple times. At the moment, we've ignored it. We haven't analyzed, we have to, that's the next wave of analyses. We just
So-
look
That
sort
try
of
and keep that as a
overall.
variable.
Certain things
Yeah.
like on the technology, like certain
Yeah.
things presumably you could do something like that,
Yeah.
where like filter it later.
Yeah, we
Certain
know
things
who
you
got
we
what
wouldn't
version,
have.
you know, so we
Certain,
have,
like, but also there were certain technological pieces on that study, which was a 7-year VR study started in 2008 or whatever it was, right before you were born. But that certain things could have updated but did not, right? The headset stayed the same the entire time, but the hardware and the software changed slightly at each site over different places. So there were some things that didn't change, but it's also not unique to like novel technology per se, right? Because during the same time window, the diagnostic criteria for PTSD changed, and the study had to keep the original diagnostic criteria. Because if you were to change your diet, like suddenly you have a different population, and like you can't filter that. So and that type of thing just happens.
Yeah.
And you
But
like a lot of our
but
research
DSM,
is
I'm more comfortable making the argument that we stay with DSM-4 criteria.
right. No,
It's
exactly.
harder to
So we
make the
wouldn't change.
argument about
When the world
technology.
changes under you
Yeah.
too, and it's
Or-
like, this doesn't mean
yeah.
what it used to
or a
mean.
surgical
Um,
technique, it's a common problem, but it often gets ignored.
Yeah.
in Study design.
So, and routinely now you still see studies published with DSM-4 criteria for PTSD, which we're going to publish that paper under DSM-4 for years. And you can still find samples that were collected under DSM-3, which was the first edition of PTSD. It came out in 1980. Like that data is still used. It's just different. So hopefully there will be pieces of technological data that doesn't have to be updated all the time.
I have a question about long-term effects. So for acute pain, you could say that that you don't have to do a 7-year study in that extent if you could pull in sufficient numbers of patients, so you could have that snapshot of treatment and time. One thing I've been curious about is long-term effects of pain, and this is, so I'm stepping way outside my area of expertise, but as a parent of a kid that had interventions, the effects on the family of medical interventions. And one thing I've seen in pain studies with kids is people will ask the parents, like, how in pain did your kid seem during the intervention as one measure? And I was like, well, that's interesting. And then I was thinking about this, and I was talking with a student collaborator who had a serious medical condition, and he said that he thought that his parents had taken them years to sort of recover from it. So this seems maybe sort of fanciful, but I'm curious if you look at sort of family reactions to pain, and it's like when someone goes through a painful condition, everybody goes through a recovery period. Is that something that's being taken into account in pain? So I see a big
Yeah, so I think it's more well developed in the pediatric literature where people understand the impact is not restricted to the individual, but families and siblings and parents are equally affected, often in a negative way. Less examined in the older adults, but one can imagine that the adult child, so I care for people in their 90s who have adult children in their 70s, and what impact does it have on the 70-year-old coming in to see the 90-year-old with excruciating pain? So not well examined. Lynn Martier at Penn State is a psychologist who's very interested in this and is looking at it, but very little research has been done on looking at family impact in later life. But we know
really
it has an impact in pediatric patients, but one can imagine it's going to happen in older folks as well.
What would be the name for that kind of stressor on the family, like post treatment? Is there because I'm in the position of like, I'd like to read some papers on this. What is the terms I should be searching for? Like consequence of of pain,
And the
familial
family.
consequences
Yeah.
of pain.
Caregivers.
Yeah, caregivers.
Caregiver,
Yeah.
consequence of pain on caregiver.
Yeah, can connect you with Lynn, who's very good and probably has,
I wonder if having social connections through like virtual environments in terms of social support, if that might be
Mhm.
something that could also have effects on the caregiver. If you could participate in some way other than being with someone physically when they're undergoing a painful treatment.
And I think that also points to really what some of the other mechanisms of virtual reality pain modulation besides distraction, what they could be. Because I think for chronic pain, probably most of the benefit for non-pharmacological pain medications is like instilling coping skills, providing relaxation, providing capacity to cope with pain tomorrow, not just right now. And for kids and for older adults, right, your support network, if it can facilitate that level of skill building for you, that is so powerful. But if it can't, if that network becomes overtaxed, becomes more brittle, then it can be an added stressor, in fact. And I assume this holds for older adults. But certainly, so like the more educational components, the more relaxation focused components of virtual reality, and probably these in development more social components, which I think are hugely important, would be very valuable for that longer term gain. What can snowball?
I have one more question about the social component, and then I'll stop because I feel like I don't want to monopolize, but is there much work on connecting patients socially with each other? I realize there's a big privacy implication, but support groups are, like around the support group paradigm in terms of pain. Do you see any potential in a virtual space where you could connect people with peculiar, situations?
I would just say one of the things that I've remarked over what is now 15 years of doing group-based self-management, largely psychoeducation with a little skill building, and we would call it CBT light for pain management in older adults, is the value of the support that people get in groups. And when these groups are done, invariably what we hear is, I wish we could continue the group. You get it for 8 weeks, you get it for 10 weeks, and people build rapport and they are asking, how do we continue? So I think that is a great suggestion. To what extent can VR and other technologies promote ongoing group cohesion, which is built and then disappears at the end of this time-limited therapy?
Oh, that's such a good, I didn't think like when the study's over, then the study's over.
Right.
So,
It's actually interesting that you say that because we hear about the benefits of groups, yet I work with someone who does psychosis research, who proposed CBT group component. I found there's people telling us it takes too long.
Takes too long
To
in
form
group.
the groups and, to run the study, where we know it's actually very beneficial.
because people are not co-located, there's not enough
Yeah,
people
it's-
to create a
yeah.
group in that
That's
environment.
a good idea.
Wow, that's a multi-site
So
for
the
sure.
virtual
Yep.
element
Yeah.
aspect.
So we did now publish in 2018 a meta-analysis looking at CBT interventions for pain in older adults and examined a bunch of moderators. What are the factors that may moderate treatment outcomes? Group versus individual therapy was one of them, and groups performed consistently higher. The effect sizes were higher in group. So it supports this idea that there's some benefit in getting this thing together.
This is maybe sort of a sub question for you, but I've actually relatively often in the years I've worked at the burn center, sort of, because the burn ICU, it's an ICU, patients have individual rooms that are often quite isolated certainly from each other. But I've frequently met with one patient who had a set of concerns, and then in the same day met with another patient who had the exact same set of concerns 30 feet away, but will never meet each other, basically. And I have wondered with like this type of technology, or even more basic, just in-person groups, but that is actually functionally quite difficult for many burn patients, whether there could be added value in putting them in a virtual space. And there are other concerns for burn patients that are really potentially synergistic with that. Many people are concerned about their actual appearance, or want to speak to other survivors to talk, like strategize, are interested in talking about how they manage pain, or would benefit from hearing. I don't know, there have been efforts at various burn centers to make it more of a group.
Yes, yeah. So either a lot of data, is suggesting that for burn patients, group therapy benefits, their outcome. You know, not only their reintegration into society, but their overall functional outcome later on. Because the thing that patient wants to know is, what is my skin going to look like? How much scarring am I going to have? What type of skin graft would cause what type of scar, contracture, and stuff like that. So there's a society called Phoenix Society Burns, where they have a bunch of burn survivors acting as trained volunteers that will go around and then talk to patients. And then we do have a fairly active group here in New York that will come. We have a list of volunteers, and they will come to our unit and talk to our patients. So if we can somehow set it up as a virtual world, I think that would definitely benefit our patient population.
Because right now that process takes a few days at best to get
Exactly.
the
Yeah.
volunteering.
And then we'll also try to match the right volunteer. And then see what their availabilities are and stuff like that. So sometimes it's hard to match the exact volunteer that we want.
Right. So if you have a bigger network.
Right.
Sounds like we just need to get funding for giant multi-site studies to connect.
I think another cool piece of that is building asset. Mechanisms of academic community. So like whether it's move it as around or like help advocacy and maybe more on the front end of like the moments that they are experiencing severe community interaction.
Great idea.
So short and long term. Outcomes.
Or like if it is like it's just a help have it kind of stand that up. Or how to incorporate maybe like go ahead with the social aspect and practice do something virtually.
Is there a self-efficacy? So if you have peer-to-peer counseling, is that like would that be a component of that where you could build self-efficacy? It's like it seems like a big lift for patients to be like, you are a patient and I'm going to ask you to be a peer counselor at the same time. But is that something where it would be like, well, you're going to record a message for someone later, which I know is something that people will often do in and out of virtual environments where it's like, you learned this lesson about resilience, and we're now going to ask you to record a message for the next person that comes after you. Like if that would be a way to augment the social component without having to always have people in the same space if they're maybe not ready to be with someone else. It's sort of a way to scaffold into social interaction.
Yeah, I think that's a really cool idea. I think control over teams, so like future focus and emerging involvement.
I know that there's a lot of work. Like I particularly like the project on visualizing healing. I think is a really profound intervention underway.
Study's been done where, going back to the skill building idea, where you were teaching people relaxation, let's say, to determine whether teaching in a VR environment versus the internet versus in person makes a difference. Because ultimately, we're wanting adoption of the behavior outside of that instructional time. And is one, I can imagine it depends on a person, but have people looked across these venues to see whether uptake is different?
My answer is yes. I'm sure you know more than.
Well, no, not necessarily, because I'm thinking of actually a different educational environment. So I want to hear your yes, because I always feel like
for clinical
for
environments,
face-to-face versus virtual reality, I think it's always like, why are we? Sometimes you can't do face-to-face.
Yeah. So I think in clinical uptake and psychoeducation stuff in general, and you can go to the clinical psychology side, I think there's pretty clear evidence that videos are less efficacious as far as transferring knowledge and maintaining that knowledge for longer term. But that's not, and I'm less familiar with the virtual side. I'm aware that there is research on the VR side for similar tasks, but I actually sort of bet that there's a lot of nuance I'm not at all familiar
Well,
with.
there's little research, right? Like in any
Okay.
VR, like I feel like in other than the big spaces of, it's like for pain, for PTSD, for simulation training, it's like there's these sort of established strains, and then there's like interesting stuff on outside of simulation on learning. So learning's a huge category. So I have some specific projects in my lab outside of the clinical space where I'm like, currently we see equal results for learning unless people have a certain amount of video game or VR experience.
Mhm.
But that's more abstract learning. So I think simulation, there's a lot of support for the hands-on component.
One thing that I'm sort of thinking of that might be related is situation-dependent learning, where the classic finding that like students who are able to take a test in the classroom where they were taught the subject perform better. At least that's a relatively robust finding. There's some variability. If you take a test in a virtual environment where you learned that thing virtually as well, it seems to be consistent, at least to a degree. At least according to one paper I've seen published and a high school project that I helped supervise that will never be published probably. But that's promising, right? It seems to have the same, because it's immersive, because all those many multifaceted cues are there. It seems to actually promote that level of accelerated learning and maintenance.
It also sounds like as the company, we need to think about the right outcome measures. They don't have to be necessarily the same as countries. I think someone was talking today about the fact that acquiring knowledge is one thing, knowing where to find knowledge.
Mm-hmm.
It can be more important for the understanding for outside knowledge. It sounds like we need to be thoughtful about it.
Can I ask what you feel like the role of qualitative data are during the process of piloting, applying for funding, and also just talking about the outcomes, because there's questions we didn't think to ask or that didn't exist when the study was started, like how statisticians and designers, as study
The
designers.
funding question is we'll put it aside for a second, but you're talking about doing exit interviews, so I think anything that's relatively novel, and I'm a numbers person, but boy, do I love when I hear that somebody's doing an extensive exit interview to learn about, are we totally missing the right outcome measure? And are we seeing, and I've done studies where traditional intervention studies where what we thought our primary outcome was didn't budge at all. A TBI cognitive rehab study that I did years ago, and neuropsych tests were the primary outcome measure. Well, they didn't budge at all. There is nothing you can do with someone with a chronic TBI. You are not going to get their reaction time much faster. You're not going to get their, But they anecdotally said, I can go to work by myself, or I can go to the grocery store by myself. I can make dinner for my family for the first time. That they've learned all these functional outcomes that we never would have picked up. But we did exit interviews, and then we start developing measures. So I think in that sense, if we don't know what the exact effects are because they're new mechanisms and it's a new environment, then we might be asking the wrong questions. So I think that qualitative piece is extremely important. You also then have to have the person power to code all of that. Ask the right questions. That's right. And that's the piece of it that gets tricky, and funders are not as enthusiastic usually.
I'm glad you said that because I think the landscape's changing. In other words, even 2 years ago, for quantitative person to say the quality aim was a big no-no. Right now, I believe NIH is requiring a qualitative aim.
Oh.
And generally speaking, I think the methodology for qualitative research has been updated and applied now systematically. So I think great idea.
There's AI. I mean, there's the technologies that they go through coding in a more systematic way.
But you do need a qualitative researcher on it. Otherwise.
Yeah.
And doing that kind of work also opens up other sort of funding and investigational lines as well, right? So patient-reported outcomes and are actually sort of a really big funding source in other parts of the world, especially, but especially as opposed to like health-related quality of life, and International Society for Quality of Life is very invested in qualitative research, and are very interested in how patients perceive things, and particularly talking about pain, right, which is inherently subjective, right? I kind of wouldn't believe that there was an objective version of pain as well, right? But it's
I'd love to know about it.
yeah. But it's like for something that is subjective, right? We can provide standardized, measures, but we're never going to capture that person's experience except through their ability to translate it into words, basically. So I think that's a really good avenue to pursue.
Although NIH is funding a lot of biomarker work and with people doing fMRIs to try to get more objective measures of pain for this reason, because it drives clinicians crazy, the subjectivity of it all.
I wouldn't believe it.
No, I'm in your camp. I'm not saying we're going to get there. I'm just saying they're funding a fair amount of research to try to make it an objective kind of thing.
Although there are things you can collect, and we were talking about this before, there are things you can collect in a VR environment where you can sort of get proxies of engagement by eye gaze and attention.
Yeah, how much people are
That sort of
moving,
thing,
what they're touching.
which is hard to get outside of that kind of environment. So.
Yeah. Physiologically. We use, so in a social science context, they use pain to describe, it's like, we all agree that this is real, but you cannot give me the pain number that will mean anything for you. So if they do come up with an objective measure, I'll have to come up with another construct that is both real and subjective, and subjective, which will be a good teaching opportunity for me. Are there so this is my last question, and then I'll. Are there qualitative questions that you would recommend for people doing research outside of the patient population that would translate or would translate? Like we can't ask our participants about long-term suffering because they don't necessarily understand it if they're coming in for an induced pain task, or there are things we could ask about their distress that would be informative for the clinical population.
I have a first thought, and then I want to hear what everybody else has to say, I guess. My first thought is one of the things that I think is hardest about providing non-pharmacological pain interventions in general is expectations and buy-in tend to be very low for most people. And so I am very curious and eager. I'm curious about different people's expectations for how is breathing going to help me feel better, or like you want me to just not think about my pain. That doesn't sound very useful. And like I can tell them, no, it's extremely useful, but nobody believes it until they experience it. And VR has the benefit of being totally new, a device that sort of naturally overcomes that for many more people than just telling them about mindfulness or something, right? And so my sort of, one of the things that would be hugely helpful is sort of figuring out how we can promote these methods, have them be perceived as potent, just as potent as narcotics and things like that, and get people excited about them because they seem exciting. That's sort of a broad question though, and I think there's qualitative stuff there.
I wonder if there are cohort effects in a sense of younger people being more willing to adopt them, or not adopt, but at least engage. 70s and 80s are pretty fixed and are pharmacophilic, and we hear this all the time, which is you're obviously telling me it's in my head if you're trying to get me to do this. Yeah. And so I do think it's harder as you get on in life for people to sort of recalibrate and think, well, maybe I can try this, but maybe not. I don't know. Yeah.
So in that line, well, that would get into the kid thing where it's like, well, are kids more open to new experiences? But it's like, what do they think the new experiences even are? It's like,
But I think fundamentally the issue is we often forget about engagement. How do you engage these people to at least be willing to try it?
Right. And it's kind of a nice point where it's like engagement, like nobody's going to be like, well, the effect, like in the short term, if it's effective, then it's like, that's already like one win. It's like, you know, even if it was like, it was effective because it was a novel experience every time. It's like, well, if that, if you can make a novel every time, then I don't think anybody would object to that being a successful treatment. So it's a neat idea that you could leverage novelty forever.
Yeah.
It's like infinitely do that. We are almost on an hour, so I want to respect everybody's time in the sense that we can keep talking, but I know that everybody's busy, and we do not have to stick around till 4:30.
I have a quick question. So I know we've been talking a lot about using kind of like VR to manage like pain. And maybe I'm like completely off here, but like that seems like a very like responsive, like responding to like a problem. Like, do you see any application of like VR as like a preventative measure, like ahead of time?
Yeah, I think, with mindfulness training, it's pretty hard for people to do that in the first place, but it's more effective with stress management strategies. People do that over time and they're good at it. So I would think with a sleep application, you would really build up people's skills to get them, especially if they're having some level of chronic pain and kind of hurt anyway, maybe to like build that up and prevent worse pain intrusion.
So NIH is very interested in the transition from acute to chronic pain and thinking about ways to prevent it. And I do know they've funded research in Iowa looking at psychological approaches of skill building prior to surgery, because surgery is is a place where many people go in for acute pain but end up with chronic pain after surgery. So I don't know whether there's work going on with VR in this setting, but it's an important area that could be looked at.
I feel like with the getting people used to the environment addresses it in a tiny way, like that component of being like, here's the procedure you're going to be going through, so you're not afraid going into surgery. But I feel like that's the closest thing where it's like your outcome is affected by your attitude and expectations going into the intervention. So if you're completely terrified, then your outcomes will be worse. And if we can acclimatize you using a virtual environment, they'll be better. But that's the main example I could think of, where you would walk people through the procedure beforehand. But that, I feel like that would oblique it to.
Yeah, I think for our patient population is that they have a background pain. So if you have a burn, you always have a background pain. And then there is a procedural pain, when we're changing dressing and stuff. So I feel like that's something that we can look into, some of using VR while they're in the background pain phase to prevent them from having too much pain response, when they're getting their procedures, so that we can somehow get them the procedural pain. We haven't looked into that because that will contaminate
For a particular study.
exactly our particular study at this point. But
There's another study.
exactly.
Yeah. I mean, we in the burn center, you and the nurses we provide pre-medication with narcotics before these procedures, and so maybe we need some pre-VR.
Yeah.
Yeah.
My best question about recruitment. So I think I've seen a couple places on the posters downstairs that recruiters say there is some challenges in getting participants in for recruiting. I'm not familiar with normal medical research. I don't know if that's a normal percentage or a normal. Is it more challenging, really, is what I'm asking, to get patients to do VR? And if so, do you think whatever factors driving that is going to apply to actually using it in application? There's still going to be that barrier to getting people to use it.
Can I answer first?
Sure. Yeah.
I don't think it's going to be a problem writ large. It has been a problem for the specific study that we've been trying to run at the Burn Center, but not because of VR. I want to just be really clear about that. The VR has not been the problem. Patients are super engaged. The staff has been super engaged. Everybody wants to use it. We were silly and irresponsible and didn't pre-plan enough and didn't recognize the trends in actual service delivery that were going on. So as Abe mentioned, we thought there were a lot more procedures being done in our relatively narrow population that we had isolated than actually ended up being occurring in the study time period. So that was one thing, we just misjudged the services. And then also we were very constrictive in designing our sample. so that we only had English-speaking patients because we wanted to assess them in English. We restricted the age range and the burn size to various types of settings, and given the VR, they had to not have facial injuries. And it turns out that in the burn ICU, the combination of that series of exclusion criteria excluded a lot of people who would have benefited from VR. And just for our own experimental design studies, like we didn't do a good enough job in setting up the inclusion and exclusion criteria. Some of it was avoidable, some of it was not, I think. But none of it has been due to the VR.
Yeah, I think the way we designed the study, I thought after we designed it, it was a great study on paper.
Yeah.
Because it has, you're using patients at their own control in terms of power the study was excellent. Yeah. But yeah, due to what Andrew was saying, all the exclusion criteria, and then we also realized that patients don't function as we expect them to. So sometimes the dressing changes are not going to be happening on a certain day.
Yeah. With staffing issues that made it hard to do like weekend change.
Yeah, exactly. So a lot of it end up being on weekends because we don't close the burn unit down on weekends. So yeah, so we run into a lot of problems with that. So that's why the recruitment seems well. Yeah.
I think it speaks about the value of feasibility.
Yeah.
And actually document it. So,
Yeah.
But going back to recruitment, I think so much of it has to do with what the ask is. What are you really asking of this person? How many trips do they need to make? What's the time commitment? And so those are big factors that dictate whether a person's going to be willing to come in. And then typically compensation, and you have to look around to see what other studies are doing in terms of compensation, because that could obviously serve as an incentive to get people to come in.
Which is a funding question.
It's rarely the VR, I agree. I think it's certainly, clinical trials with PTSD, with TBI, those are notoriously hard to recruit into. And actually, there was a lot of, at least with this one, a lot of enthusiasm for the awesome treatment. So most people prefer that. But yeah.
Yeah, I guess that's actually, that would be my takeaway for those of you who haven't been involved with them. It's like they're hard. As somebody who's peripherally involved, I'm like, this is a poor pre-tenure strategy. So that's the other thing where it's like, for me, as a non-clinician, like I'm doing this because I think it's important, but it's not even, it's a tiny component of my package. Because they take a long time. Which is maybe more information that you guys needed to know.
But we feel your pain.
Yeah. You got to do what you think is important. I can't help but ask, like, is there a way? So the issue is if a lot of people want virtual reality, then it's probably kind of sad to walk past their bed and be like, no, you don't meet the criteria. But that's a funding constraint, right? Like you can't use those folks in the study because you don't have money to pay for them because you allowed for the people that you needed to answer the question, and there's just no real way around that. Is there a way? I'm assuming you would have to augment it with a purely philanthropic funding source if you wanted to do that, but it's just a sad truth.
Yeah, I mean, for the types of commercially available VR that are already available, I think in the next couple of years, we'll see just clinical units having a few on hand and providing them to patients with, the standard nurses administering them. For us, it's even though the technology is basically ready for that, for us, it's like we own the things for research purposes, and we want to supervise their use. And so it's not just the hard thing, it's the time, it's the commitment of the person or persons who have to be there throughout. And because when we're doing the study, it involves, bothering the nurses in particular a little bit to slightly go out of their way to let us into the room and to, acknowledge when we need to ask the patient a question that we're not going to be that invasive. And those are,
that's a huge cost.
Those end up being costly, especially at the time of people who could be recruiting for other studies or finding new patients
Yeah.
to recruit, which is such a time-consuming task. So.
But it raises the issue in the burn unit. I'm guessing you're using it for relatively short periods of time, although it could be weeks. But in the end, the course of what you're treating is things do get better. For certain situations, things aren't getting better. And so we recently put in what's called a UG3 grant, and there was a criterion in the grant application where they said you have to comment on what you will do for people who seem to benefit from the therapy after the study is over, which actually from a funding standpoint makes sense. So you got somebody who's, in this case, it was transcranial stimulation. What do you do with people who think, I'm really better, but the study's over, so they go back to the way they were before? And our response was these things are commercially available, and that the compensation they would get would be enough to purchase a unit, which is about $200 bucks.
That's great.
But I was pleased to see funders stepping up to the plate to, address this, which is a real issue.
Oh, that's huge. That's nice. Does everybody know? So I've met a lot of people for the first time. Does everybody else know each other? There's a lot of WILD folks. Would it be interesting to have a list of just to send out an email with everybody's name?
Definitely.
So let me get, thinking if I have a piece of paper that's not absolutely disgraceful. So why don't I could pass my laptop around and then I'll just send a group email, just because I feel like it would be sort of useful to have everybody in the loop. Assuming that my laptop is not as tired as I am. Okay, I don't want to lose it, but yeah, that might be faster. I can type it in before the end.
It's very, very trusting of you
What?
to offer your laptop to
Oh, there's nothing
strangers.
exciting on my laptop. I lead an extremely mild life. So you might see like an IKEA catalog on there or something. So I will take the piece of paper actually. And then, oh wait, will I? No, I'm going to offer up my laptop just to show how much I respect all of you guys and how confident I am that there's nothing interesting on here. Can I start with you?
You want me to type it in the two or in the?
Yeah, you can type, or you can put it in both so people know your name. Because I don't know if your name.
So here's a question for the Ithaca folks. Is the peak color come and gone? Are you beyond the peak color?
We were right in the middle of it like last weekend. Because we did a lab lake tour, and it was, for once, the timing was in our favor because it was really, really pretty. So when we get back, it'll all be on the ground probably.
How many snows have you had so far?
Haven't had our
No
snows yet.
Friday, I think it's coming Friday, so we are first. Allegedly.
Really?
Yeah,
Really?
it's snow/rain, 40 degrees. Like it's.
Oh,
I
well,
confess.
that's, okay.
Very strong.
In order to cheer myself up, I'll say it's maybe snow. No, it's been a pretty fall. It really has. I guess we may have somebody being live streamed. I don't know, so we could ask them. But yeah.
Maybe they can live stream us, take it outside.
Right.
Okay.
You don't get quite as much foliage out here.
No,
That's
it's
weird.
kind of an urban foliage, really.
little bit.
Yeah. Yep. That's
The
true.
pigeons are in bloom.
Oh. Yeah, we'll be heading back. So I think the bus actually leaves kind of late. It leaves at 6. So there's an opportunity to go and hit the park before everybody buses back out. But I drove, so I might actually bolt as soon as, because I was thinking about it. And it's like, I'm going to try and drive out of New York.
Oh, yeah.
4:30 in the afternoon.
Because
It's
it's
like-
Friday afternoon.
Yeah. Yeah. So we'll go ahead.
You probably should leave now.
Absolutely.
Well, I'm looking at the clock. It's like
You should have left it.
I should
11
have
a.m.
left already. Yeah. I'm very patient.
VR while driving, though. Not advised.
Yeah, not yet. I actually have a
That's right, you're
friend working on that. It's like someday we'll be in VR in the car, and then that's like, but then it has to be a truly self-driving automobile,
Right.
because you will not be able to.
Then you won't be
reverse
driving.
fast. No.
That's
not
right.
for a while.
Or you can have the.
Okay.
Traffic is not.
Traffic.
Safe
Traffic.
travel.
Yeah,
Thank you, everybody.
Desensitize you.
Right.
So thanks for participating, because this was kind of a fun opportunity for me to interrogate everybody, but we'll exchange emails.
Interrogate at will.
Yeah, we'll have some opportunity to chat more, or at least have everybody's email in our back pocket. And I'm going to tell Muriel that
It's great that you came down for the, even though it was a really brief trip, it's wonderful that you all.
Yeah.
I mean, I have really enjoyed this, and I appreciate the buy-in from Lyle in particular. It's been really nice. I see we're making our way around. So now I think we're in a way done.
I recommend people putting the rest of the emails into the CC because this will not.
Okay, yeah, I think some people were also duplicating in the body of the email so that you have doubles, but whatever people have, I'll hit send as soon as I get it. Okay, nice to meet you.
You too. Have a good trip back.
Thank you. However long it may take. So is it a beginner panel? Is a beginner panel? I heard there were like 15 people down there. Are they done?
I don't know.
Okay.
But I told them to text me things and stuff. They didn't. So I think
Okay.
that's good.
There's like 8 people down there, so I'll go
I
ahead.
really wanted to come to visit.
Yeah, well, I'm happy to see. So we have what, 15 days before another review?
Oh.
Yeah. No, it's
Yes. 2 weeks.
well, do you hear
Because
what
I'm
people?
so
So
busy,
these
so-
are folks looking at longitudinal studies and social interaction, and they also are not aware.
Yes,
Get the data out.
that's right. We could use it.
Nice to meet you.
Yeah, nice meeting you.
Go ahead and disappear. Go to MoMA. Now you can go to MoMA.
Good job. Great job organizing.
Thank you so much for accommodating
thank
this
you.
format, but I
Yeah.
really, makes me so happy to get the chance to at least ask some questions of you guys. And if you ever make it up to Ithaca,
Yeah.
you need to come visit. Okay, I'm gonna send this now before it gets deleted.
Thank you for the spirit of collaboration.
Yeah.
I was.
Yeah,
That's
this
what
was
this
great.
is
This
all
was-
about.
Yeah, I'm glad I didn't go to the health conference. My company's a finalist in the health conference, so I just,
Oh, did you bounce back and forth? Oh,
well, it's in Vegas, so I just canceled.
Oh, wow.
Flight. So I really just wanted to try. I'm sorry, I know I was super late, but I wanted to at least thank you.
Oh, that's
Thanks
great.
so
Well,
much.
I'm happy if it was useful. I'm gonna hit, so
No,
you're on here,
yes.
right? So
Yes.
So let me hit.
Thank you. And yesterday was, I thought, really phenomenal also.
Yeah.
Oh,
So congratulations. Your panel was amazing. Your talk was great.
Like, happy to hear that. So
Yeah.
let me see. So you're Yasmin?
Yes.
Okay, great.
So it's really bizarre because there was actually not a mailer sent to some of the other emails for the conference.
Oh, really?
So quite a few people who I think actually would have really loved to attend, I told, because many of them were flying to help at various points throughout yesterday, today, and tomorrow.
People that confirm.
People who didn't know that the conference was actually happening, even people who collaborate. Deborah Estrin's group that is co-appointed at Northwell and in behavioral health testing. I reached out to them as soon as you sent everything to me, but they didn't know about it. So they sent their apologies, and I tried to go
Oh, that's
around and like,
It was,
Specifically sent to
So
the
weird.
listserv into the XR group there. So Sarah
Really?
and those folks, and they said they threw it up on the website, the XR website. Oh.
so the way that the listservs are circulated with
Let me-
tech, we don't.
Let me go ahead and make
If
sure
it's
that
not
this
sent
is-
to like the academic listservs,
oh, it
basically
might
none
have
of us
gone.
got it. Like I talked to a bunch of people, I went into my spam and I was like, I
What a
didn't
shame.
have anything, so I don't really know.
I know that
how I got
we,
it, but-
I know that, I mean, Marielle especially like stressed a lot about making sure it was on all the listservs and
sure she
repeatedly,
Yeah.
but it's, yeah, it was too bad. I was surprised you didn't know about it, honestly. But Yeah,
So you
it's right up your alley. Yeah, I told her about it yesterday morning, or no, Wednesday, I guess, yeah. Well, it was lucky, yeah.
Yeah, my gosh, I
It's
just
great.
had no idea. But they're very excited. So I told them about it, and even though they weren't able to be present, I think they would like to try to be supportive in some way.
I'm sorry,
Great.
I need stuff around to get it.
And it was nice to meet you,
Good to
albeit
meet you
briefly.
too. No, I'm sorry, I'm really,
And your former student